Assalamualaikum. Assalamualaikum.
Waalaikumsalam, Doktor.
Okay, alright. Yeah. So Ikhwan is there, and then another two siapa? Nabila and siapa tadi? Rohniatul Husna ya. Ada?
I'm here, Doctor.
Okay, Husna is there. Nabila also there. Okay. So we will discuss 3 topics in cardiology today. First one about valvular heart disease lah. Another one will be IE, and then the third one will be heart failure. Nanti yang IE itu siapa? Nabila, you need to go to you little bit faster lah. You have so many slides kan.
Alright.
Nanti pasal features nanti will repeat again in criteria of diagnosis. Yang penting tuh di deep criteria. Maybe yang features you just go through cepat sikit ya. Even etiology pun actually one slide pun will be adequate ya. As long as you know what are the common bacterial causes. Apa ya banyak di etiology di causes organism tuh. Okay, alright. So start with Ivan first ya.
Me, Doctor.
Right, you may start.
Full screen fit. Okay, Assalamualaikum and hello everyone. I'm so glad you guys could join us this afternoon. So first and foremost, my name is Mama Ikhwan bin Zuraidi. My metric number 1811519, and I'm very excited about today's topic seminar that we will discussing on some of the cardiology disease. Start off with me on the overview of the valvular heart disease. And next, the second presenter will touch about the infective endocarditis. During the next hour, we will be looking at the heart failure in the childhood. So by the end of the seminar, we should know how to relate between all of these diseases. Yes. Okay, so this is title of my presentation today, which is the valvular of heart disease. And I will begin by explaining the outline of my presentation today. So firstly, we will briefly take a look on the anatomy of the heart and also some of the introduction to the valvular heart disease. And next, we are going to look at the types of the valvular heart disease. So you should know how to differentiate between the stenosis versus regurgitation. And also some underlying causes or etiologies of the valvular heart disease, as well as the pathophysiology and also the others. This is a very important, and I will offer you guys some sign and symptom, investigation, management, prognosis, and complication in a table so that it's easier for us to differentiate between them. Next. Okay, so let's recap some general anatomy of the heart valve. Okay, so the valve, wherever they are present in our body, for example, in the heart valve or also the femoral valve, femoral vein. So the main function is to provide the unidirectional flow of the blood. So have this in mind. So when this valve cannot do this function, so it will become incompetent and various valve lesions can be occur. Next. Okay, so the heart is the muscular organ which pump blood through the whole body. So it contains 4 chambers through which blood flow into and out of the heart. So here we have left atrium, left ventricle, right ventricle, and also right atrium. So the right side of the heart will pump the deoxygenated blood to the pulmonary circulation, while on the right side of the heart will pump the oxygenated blood to the systemic circulation. So between these chambers of the heart, we have the 4 valves. For the first one, we have the tricuspid valve. So the way I will remember, the tricuspid, right tricuspid valve. So from the name itself, it have three cusps or leaflets, and also the pulmonary valve. On the left side, we have the mitral valve, or the other name bicuspid valve, because it has only 2 valves, and also the aortic valve. So the thing is, the mitral valve is the only valve that have 2 cusps, while the rest have the 3 cusps or leaflets. Next. Okay, so let's move to the some introduction to the Okay, so the opening and the closing of the valve is what creates the lap duck sounds of the heartbeats. So in the normal patient, we might have we can hear the heart sound like lap duck, lap duck, lap duck. Okay, so for the first heart sound, the lap sound, or the S1, is caused by the closing of the atrioventricular valve, which are the tricuspid and also the mitral valve. So this happened during the beginning of the systole, after the atrium have pumped blood to the ventricles. While for the second heart sounds, the duck sounds, or the S2, is is caused by the closing of the semilunar valve, which are the pulmonary valve and also the aortic valve. So this happened during the end of systole or the beginning of the diastole, after the heart has ejected the blood. So on the right diagram, you can see the phonocardiogram, which is the visual representation of the heart sounds. So in the normal person, we have only first and second heart sounds, lap duck, lap duck. And if you have problem in the heart, so there will be additional heart sound, for example, S3 or S4, and also can be abnormal sounds, what we call as the heart murmurs. So heart murmurs is a whooshing sound, whoosh, that is produced by the turbulence flow of the blood. So it can be a systolic murmur, or it can be diastolic murmur. And for example, the systolic murmur, we have the aortic stenosis. So we will go on this after this. Okay, next. Moving on to the introduction to valvular heart disease. Valvular heart disease is characterized by the damage or defect in one of the 4 heart valve, either the mitral, aortic, tricuspid, and also pulmonary valve. And the most common problem are acquired left-sided valvular lesion. So, so we only concerning on the left side of the heart, which are the mitral and also the aortic valve. So the mitral valve is control the blood flow from the left atrium to the left ventricle, while for the aortic valve, control from the blood from the left ventricle to the aorta. So that's why we concern only the defect or damage in these 2 valves, mitral and aortic, either stenosis or regurgitation. And also the prevalence of the valvular heart disease is estimated at 22.5% in the US population, and sharply increased after the age of 75 years old by 30% that have at least moderate aortic and mitral valve disease, with aortic stenosis being the most common degenerative valve lesion. Next. Okay, so moving on to the types of the valvular heart disease. Okay, valvular heart disease, it can be in 2 ways, either the stenosis or regurgitation. So any of 4 valves, it can affect all of it can be stenosis or regurgitation. For example, if the stenosis, we have all 4 valves can be affected. For example, mitral stenosis, aortic stenosis, tricuspid stenosis, or pulmonary stenosis. Yes, next. And here, so we should know what's difference between the stenosis and regurgitation. Okay, generally speaking, the valve, it can get rigid and it cannot open well. That's what we call as the stenosis. While for the the valve, it also can get leaky and allow the backward flow of the blood. That's what we call as the regurgitation. Next. Okay, this what I have mentioned earlier. For the stenosis, the heart valve doesn't fully open due to the stiff or partly fused leaflets. So what will happen? There will be impede or interruption of the normal forward blood flow. So you know the valve is narrowing, so the narrow opening make the heart work harder to pump blood through it, and it can lead to the build up of pressure, and also can strain the heart and also reduce the blood flow towards the body. That's for the stenosis. And for the regurgitation, the valve does not close tightly. Okay, I will give, for example, if you have the mitral valve. Okay, mitral valve is between the left atrium and left ventricle, right? So when the blood is flow from the left atrium and left ventricle, so the valve cannot open, cannot close properly. So there will be some backward flow from the left ventricle to the left atrium. So that's why some blood will leak backwards across the valve. As the leak worsens, the heart has to work harder to make up for the leaky valve, and the leakage can increase the blood volume and also the pressure. Next. Next. Okay, let's take a look on some of the things that can cause the valvular heart disease. Okay, as I mentioned earlier, we just only focusing on the left table. There we have the mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. Of course, there is a lot of list etiologies, but I will just only mention 2 or 3 examples enough today. So for the first one, okay, before that, I will just like to remind you that for the valvular heart disease, it can be caused by the congenital or acquired causes. Okay, so for the first one is a mitral stenosis. It can be caused by the rheumatic fever. Rheumatic fever is because infection of the group A beta streptococcus infection, or it can be congenital causes or severe mitral annular calcification. Okay, so for the mitral regurgitation, of course there is a lot more, but it can be subdivided into the acute and chronic causes. For the acute, the endocarditis is quite frequent, and it also can be seen in the papillary muscle rupture or trauma. And for the chronic causes, the important is the myxomatous that eventually it will cause the MVP, which is the mitral valve prolapse. And other causes could be like the rheumatic fever or endocarditis, heel endocarditis. And the next one is the aortic stenosis. So the causes can be congenital, either bicuspid aortic stenosis or unicuspid aortic stenosis. You know, the aortic valve is actually have 3 cusps, right? So if the congenital causes, it can be bicuspid or unicuspid, and it can be caused by the degenerative calcific, or the other name is the CAVD, which is the calcific aortic valve disease or rheumatic fever. And lastly is the aortic regurgitation. For the aortic regurgitation, we actually can we can classify it into the location of the disease itself, either in the valvular disease or the root disease. For example, if the valvular disease, you can see here, if can be congenital causes, bicuspid aortic regurgitation or endocarditis, or even if the root disease, for example, the Marfan syndrome, it's quite important. Okay, next. Okay, let's move on to the pathophysiology, the most interesting part. Okay, so we go one by one. So the first one is the mitral stenosis. Okay, remember the mitral stenosis. Mitral, the valve between the left atrium and left ventricle. The stenosis is the valve cannot open properly. So okay, the first the blood is flow from the left atrium to the left ventricle, right? So if the valve cannot open properly, So there will be increase in the left atrial pressure. So the left atrial will gonna dilate. So if there is increase in the left atrial pressure, so there will be transudation of the fluid, means the filtrate of the blood through the vessel wall to the lung interstitium. So at this point, the patient might present with the dyspnea at rest or at the minimal exertion. So when this increase in the left atrial pressure, this actually will cause the pulmonary venous hypertension. So you know, the pulmonary veins is the only veins that carry the oxygenated blood from the lungs to the heart. So it's connected from the lung to the left atrium. So when you have the pulmonary venous hypertension, you might also have the pulmonary arterial hypertension, or known as the pulmonary hypertension. So you know, the heart is also supplied by the pulmonary arterial. So that's why it has pulmonary arterial hypertension. So when you have the pulmonary hypertension, it will also cause the right ventricular hypertrophy, where the heart is pumped even more harder to eject the blood out of the heart to the pulmonary circulation. So that's why you will have the right ventricular dilatation, because they have to compensate by increasing the amount of the blood to stay in the right ventricle, blood ventricle. So this will cause the tricuspid valve ring dilatation and also the functional tricuspid regurgitation. So the right ventricular dilatation come up with the functional tricuspid regurgitation will cause the right ventricular failure. Okay, next we move on to the mitral regurgitation. Okay, again, the mitral is between the left atrium and left ventricle. Regurgitation is the valve cannot close properly. So there will be bad flow of the blood. There will be leaky forward and leaky backward of the blood through the valve. So the blood is flow from the left atrium to the left ventricle. So when the valve cannot open and cannot close properly, so the part of the blood in the left ventricle will regurgitate into the left atrium during the systole. So the blood volume in this left atrium will increase, and the size of the left atrium is also gonna increase. So that's why we have called the giant left atrium. So because it has to pump, more blood. So the volume of the blood returning from the left atrium to the left ventricle is increased. Okay, you know, during the systolic, when the contraction is occur, so the heart has to pump more blood, sheer amount of more blood. So that's why we call as the diastolic overfilling of the left ventricle. More blood is pumped from the left atrium to the ventricle. So it will eventually cause the left ventricular hypertrophy and dilatation. You know, when there is hypertrophy and hypertrophy, so the myocardium will be thickened, and also it is also part of the compensatory mechanism, and it will eventually lead to the left ventricular failure, and also the pulmonary hypertension and right ventricular failure. So what I would like to highlight here is that the mitral stenosis and mitral regurgitation, both of these can cause the right ventricular failure. Okay, next. Okay, moving on to the aortic stenosis and also the aortic regurgitation. Okay, so for the aortic stenosis, okay, aortic means between the left ventricle to the aorta. So the stenosis is mean the valve cannot open properly. So the blood is flow from the left ventricle to the aorta. So when the valve cannot open properly, so there will be left ventricular outflow obstruction that will lead to the increased left ventricular systolic pressure and also reduce the aortic pressure. You know, when there is the obstruction or the opening of the valve is too small, so there will be pressure, particularly in the left ventricle. So that's what caused the left ventricular hypertrophy. You know, the hypertrophy, the blood will ejected more blood to the rest of the body. So so the left ventricular hypertrophy, it will cause the left ventricular dysfunction and also the myocardial ischemia. You know, the hypertrophy, when you have the hypertrophy, the myocardium become thickened, and also it will increase oxygen demand. So when the blood flow cannot compensate that increased oxygen demand, it will lead to the left ventricular failure. Okay, finally is for the aortic regurgitation. Sorry, again, aortic is from the left ventricle to the left atrium, and for the regurgitation, it is mean that the valve cannot close properly. So, okay, the blood is flow from the left ventricle to the aortic. So the valve cannot close properly. So there will be bad flow of the blood from the aorta to the from the left ventricle to the aorta, from the aorta to the left ventricle. Okay, so that's why it will cause increase in the left ventricular volume, because you know right now the left ventricular will receive from the two sources of the blood. First one is from the left atrium, and the second one is from the backward flow of the blood from the aorta. So so there will be increase in the left ventricular mass, because it has to pump more blood from the left ventricle to the rest of the to the aorta, to the rest of the body. So increase the left ventricular mass or the hypertrophy, it will cause the left ventricular dysfunction or myocardial ischemia. So again, if you have the hypertrophy, the myocardial will become thickened, and it will increase the oxygen demand. So if the blood flow cannot compensate that the increased oxygen demand, so that will lead to the left ventricular failure. Okay, next. Okay, so the last part of my presentation, I will touch about the others. Okay, I have made the table for you guys to differentiate between all of this type of the valvular heart disease in the definition, causes, signs and symptoms, investigation, management, and also complication and prognosis. Okay, so this is just like I want to recap some knowledge. Okay, so for the mitral stenosis, it is an obstruction to the left ventricular inflow at the mitral valve, and for the mitral regurgitation, it is a bad flow through the mitral valve during the systole, and the aortic stenosis is an obstruction of the blood flow across the aortic valve, and the aortic regurgitation, it is a diastolic flow of the blood from the aorta into the left ventricle. Okay, for the causes, I have already mentioned earlier about the etiologies of the different causes of the type of valvular heart disease, but now what I would like to highlight here is that we have two types of the valvular heart disease, which is the acquired and the congenital one. So the thing that you must know is the acquired one is the most common one rather than the congenital one. So the example for the most common acquired one is due to the rheumatic heart disease. So the rheumatic heart disease is actually due to complication of the rheumatic fever. So when you have the fever, you might have complicate with the rheumatic heart disease. So rheumatic fever is also can cause the endocarditis that will eventually cause the valvular heart disease, either stenosis or regurgitation. So you need to know also the rheumatic heart disease is commonly cause the regurgitation rather than the stenosis. And other than that, okay, the rheumatic heart disease, you must know the common age for the that occur. So for the rheumatic heart disease, usually occur at the age of the budak-budak sekolah, at the 5 years old to the 12 years old. So below than 5 years old usually is caused by the congenital causes. Okay, so for the signs and symptoms, you can see here is nearly the same, but there's some difference. For example, the mitral stenosis, the patient might present have this with dyspnea, hemoptysis, PND, exertional chest pain, syncope, and pulmonary hypertension. For the mitral regurgitation, you can I have the dyspnea, fatigue, pulmonary edema, lethargy, tachypnea, palpitation, pansystolic murmur. So, so you must also have to know the murmur, the different murmur. And for the aortic stenosis, you might have the exertional angina, exertional syncope, heart failure, dyspnea, systolic ejection, murmur. Again, the murmur, so you must know the murmur. And aortic regurgitation, you might have the dyspnea, orthopnea, PND, fatigue, exertional angina, water hammer pulse. Okay, so next is for the investigation. Investigation usually all of this valve disease, all of this we do three things, which is that the chest X-ray, the ECG, and also the echocardiography. Usually we do these three, but the finding could be different. Like for example, if in the mitral stenosis, the chest X-ray finding you could have the enlarged left atrium, pulmonary venous hypertension, calcified mitral valve, and also on the ECG finding you might have the atrial fibrillation. And for the mitral regurgitation, on the chest X-ray you might have the enlargement of the left atrium, left ventricle, or it can be both. And for the echocardiography, you know the echocardiography, right? Echocardiography, where it uses the sound wave to produce the image of the heart, what we call as the echocardiogram. So it is to assess the size of the chamber of the heart, movement of the valve, and also motion of the heart wall. And for the aortic stenosis, the chest X-ray finding you might have the normal heart size and prominence ascending aorta. On the ECG, you have the left ventricular hypertrophy. On the aortic regurgitation, you might have the chest X-ray finding, you might have the enlarged heart and also dilated ascending aorta. And ECG, you might have the left ventricular hypertrophy. Okay, next. Next. Okay, so for the back. Okay, next for the treatment and management. Usually we have two, medical and also the surgery. So usually for the medical treatment, for all of this type, we give the same treatment as part of we want to treat the heart failure, because most of the time it will cause the complication of the heart failure. So that's why we give the to treat the heart failure. So the way I remember is you remember the 3D, D, diuretics, dilator, and also the digoxin for the medical treatment for all type of the valve. But it also can be, it also depends on the different case. Okay, so okay, so for the surgery, it might difference for okay, for example, usually in the stenosis, we do the percutaneous balloon valvotomy, and in the regurgitation, we do the replacement of the valve. For example, the aortic replacement valve. So, but it as I mentioned earlier, it depends on the complication itself. So, for example, in the mitral stenosis, we might have the percutaneous balloon valvotomy or valve replacement or to relieve the symptom. For the mitral regurgitation, we might do the replacement of the valve before the left ventricle is impaired or becomes severe. And for the aortic stenosis, aortic valve replacement is indicated in the symptomatic patient, balloon valvuloplasty. And for the aortic regurgitation, we might have the aortic valve replacement or indicated for the severe AR with aortic regurgitation with enlarged ascending aorta. So for the prognosis, usually, generally speaking, there will be good prognosis because we have provided the surgical management. So, but it also depends on the complication itself. So this is a complication for each type. You may have read right on yourself. Okay, so for example, for the mitral stenosis, you might have the pulmonary hypertension, pulmonary edema, infective endocarditis, or atrial fibrillation. For the mitral regurgitation, we have atrial fibrillation, dilated heart failure, pulmonary arterial hypertension. For the aortic stenosis, sudden cardiac death, heart failure, calcific embolization, and conduction defect. And for the aortic regurgitation, you might have the heart failure and also the sudden cardiac death. Okay, next. Okay, this is okay. On the clinical examination, we usually do the cardiac auscultation, right? So the important thing is we should know the exact location of the different type of the valve to the anatomy, to the anterior perspective of the chest. So like for example, if you have the aortic stenosis, so the best murmur that can be heard is at the second intercostal space at the right sternal border. And for the pulmonary valve, at the second intercostal space at the left sternal border. And while for the tricuspid valve, at the fifth intercostal space at the left sternal border. And the last is mitral valve at the apex of the heart in the fifth intercostal space at mid-clavicular line. Okay, next. Okay, so this I would like to just So the normal patient, in normal person, we might have we only have heard the S1 and S2 sound, right? The lap. Okay. So for the stenosis, usually when you heard the murmur, it's usually the similar. So we can so that's why the location of the auscultation is important. So to differentiate between it is either stenosis or either is stenosis or regurgitation. Okay, so for the aortic stenosis, you have the ejection systolic murmur, and for the mitral stenosis, you have the mid diastolic murmur, and for the mitral regurgitation, you have pansystolic murmur, and aortic regurgitation, you have the early diastolic murmur. Okay, last slide. So as I mentioned earlier, if usually in the stenosis we do the balloon valvuloplasty. So this is the balloon valvuloplasty, and for the regurgitation we do the valve replacement. For example, the aortic valve replacement. Either it can be biological or tissue valve, or mechanical valve. Okay. Also, this is my references. And thank you.
Alright, thank you Ivan. Saya tak dapat di Myung Park di cardiology tu, pediatric cardiology. Apa ni? So you can try to Google, boleh je. Sometimes you can get free PDF tu. Mute pula Ivan ni. Unmute pun Ivan. Tak ada. You don't have the Myung Park the pediatric cardiology textbook. It's cardiology textbook, Ivan.
Yes.
Oh, tak dengar. Can you hear me? Ivan.
Yes.
Yes, we can hear you.
Itulah Ivan tak dengar sangat suara saya. You don't have the Myung Park pediatric cardiology textbook?
No.
Okay, alright. Actually, if you read in Myung pun, you can get very clear explanation from there. Ya. Okay lah. So for all, rugi kalau tak paham ya, because everyone already explained very details and well ya, about how to recognize the valvular heart diseases. Ya. Okay, any questions? Ada question as usual. So yes.
May I have one question?
Okay.
For the management, you mentioned about 3D. This as general, right? The management 3D. diuretics, dilated, and digoxin. Not for all cases, right?
Yes, yeah, usually we give them to treat the heart failure as the part of the complication. So I mentioned that because we usually the patient might have come present with the complication of the heart failure. So that's why we give the anti failure treatment, the diuretic, dilated, and also digoxin.
Okay, so siapa tadi Nick Musawa? So the anti-failure treatment is not to treat the valvular problem, but only to treat the heart failure. Yeah.
Okay, thank you, Juan. Thank you, Doctor.
Okay, welcome.
Okay, welcome.
Okay. Okay, any others? So cari one victims ya on spot diagnosis. Wanabiha, please open your video and unmute your microphone. Okay. Mana? Hilang pula. Ada Wanabiha tadi. Hello, Wanabiha, can you reply me? Kenapa hilang pula? Maybe poor connection ko. Alright, Sharifah Hajar. Daniel Nazri left, lari pula Nazri.
Yes,
Daniel.
Doctor.
Okay, Sharifah Hajar. Pansystolic murmur. What are your differential diagnosis?
Mitral regurgitation.
Okay. Can you give other diseases that have pansystolic murmur as well? Usually not valvular heart disease, ya, bukan valvular. Congenital heart disease, most common one apa? Most common congenital heart disease. Tak ingat. PST. So the difference is the location, ya. Kalau mitral regurg, ya, of course in you hear the murmur loudest on the apex, ya, on the mitral valve projection, ya, when you put your stethoscope on the apex, ya. But the VSD, you get the loudest sound when you put your stethoscope on lower left sternal edge. Ya. So the murmur will be similar, ya, pansystolic murmur. Okay. Tuh. And then lagi satu nih, nak cari satu lagi. Warna biah dah ada lagi. Kalau cannot open video, open unmute je mikrofon.
Ya, Doktor.
Okay, so if you have patient with aortic regurg, apa you expect the murmur? What is your expected murmur to find? Aortic regurgitation. Tahu? Okay, next Nurul Aiza.
Yes, doctor. Can you hear me?
Yes, aortic regurgitation. What murmur will you hear?
Is it early diastolic murmur?
Okay, yeah, alright. So very simple, yeah. As long as you understand the hemodynamic, macam tadi Ikhwan can explain apa very well, yeah. Kalau aortic regurg, the backflow of the blood will be during diastolic phase, yeah. So it will be early diastolic murmur. Location kat mana, Aiza? Hilang lagi pula tadi.
I'm not sure, doctor.
Location of the aortic valve kat mana? Where is the location of the aortic valve? You will hear the murmur loudest.
Second intercostal
Space, okay. Right or left?
right.
Right, good, yeah. So it is apa? It is how you understand the heart diseases, yeah. Get the hemodynamic, the structure and the flow of the blood too very well. So you will easily understand, yeah. All right, very simple, yeah. Okay. All right. I think we thanks to Ikhwan tadi. We move forward to second topic. Nur Nabila. Okay.
Yes. Can you see my slide?
Yes, yes.
Right. Okay. Wait. Oh my god. Wait. There is a technical issue on my laptop. Can someone present the slide? I cannot open my laptop.
I'll present it, but
Right.
give me some time to download it first.
All right. Sorry. It's okay now. It's okay, Afiq. Sorry.
Okay.
Right. Assalamualaikum warahmatullahi wabarakatuh. I am Nur Nabila Pitizari, metric number 1810790. I will continue to the seminar with my topic, which is infective endocarditis. So these are my outline for today's seminar. I will start with the definition of IE. So according to Pitt's protocol 4th edition, IE is defined as infection of the endocardial surface of the heart, which frequently involves the heart valves. It is associated with high mortality and severe complications. So that is why early diagnosis is crucial for further assessment of that patient and to reduce mortality patients suffering from IE. So the epidemiology, as for the age, in developed countries such as Japan, IE is most common in patients with age of 50 to 60 years, and in the developing countries such as Malaysia, IE is most common in patients aged 20 to 40 years. As for gender distribution, male is more commonly affected compared to female. As for microorganism, Streptococcus species is most common in developing countries in younger age group, as well as in those with pre-existing structural heart disease. Staphylococcus is common in developed countries. So as for the site, IE most commonly affect left-sided of the heart valve, which involve 2/3 of the cases, especially mitral valve. And then the rheumatic heart disease is the most common causes predisposed to IE. About 50% of IE occur in patients with no known history of valve disease. Complication rates of IE have been reported to be high, which is 16 to 33%, which lead to a high mortality rates of up to 39%. Although surgery has been associated with high risk, but surgery has shown to reduce mortality in complicated cases and is required in 50% of patients suffering with IE. This is the local study that was conducted in Hospital Kuala Lumpur between 2013 to 2014, reported that there are 36 cases of definite IE was diagnosed in that period of 2 years, and male to female ratio was 4:1, and the median age at presentation was 36 years, and Malaise is most commonly affected, which is 60%. IVDU was the commonest predominant risk factor that can predispose to IE. And then 53% of patients had indications for surgical intervention. During that period, 5 patients died due to overwhelming sepsis. So this is the epidemiology, infective endocarditis in congenital heart disease, where the cumulative incidence of IE from birth to 18 years was 6.1 first cases per 1,000 children. And then the etiology of IE, I've divided into 3, which is bacteria, fungus, and others. Bacteria is the most common causes of IE compared to fungus, but when patient presented with fungus endocarditis, patients can have more serious complications compared to bacterial endocarditis. The most common bacteria that can cause IE is Streptococcus viridans. It is a bacterial flora of pharynx and upper respiratory tract. And patients can commonly present with this Streptococcus viridans when after dental procedure. So that is why good oral hygiene is one of the prophylaxis of IE. Next is the classification. We can classify IE into severity of the presentation and progression, either acute or subacute, because patients who have subacute endocarditis tend to live longer compared to acute endocarditis, and also by organism that cause IE and native valve or prosthetic valve, as well as either community acquired or hospital acquired. As for hospital acquired, it can subdivided into nosocomial and non-nosocomial. The nosocomial is when patient exhibits signs and symptoms after 48 hours of admission to the ward. The non-nosocomial is when patient exhibits symptoms less than 40 hours of admission to the ward. And then the risk factors of IE. So these are the risk factors for IE, such as skin breaches, renal failure, immunosuppression, and IV drug users. So risk factors of IE is basically something that can predispose to infection that can lead to IE. Presence of congenital heart disease, presence of prosthetic cardiac valves, rheumatic heart disease, and also chronic intravenous access, as well as PITS patient with indwelling central venous catheter. So all of this can expose patient to any infection. As for the pathophysiology, IE has 2 pathological mechanisms. First is hemodynamic trauma. So high velocity and turbulent blood flow cross a defective valve or through a congenital defect. This will lead to endothelial damage and platelet adherence in the low pressure site. This is what we call a Venturi effect. So Venturi effect is when blood is driven from a high pressure chamber to a defect in the low pressure chamber. So this will then create a platelet fibrin deposition and eventually will form a non-bacterial thrombotic endocarditis, or we call it as NBTE, which when colonized by any organism causing IE. So second mechanism is bacterial colonization. So when a mucosal surface is heavily colonized with bacteria, is traumatized, transient bacteremia occurs with pathogenic bacteria colonizes the NBTE. So there will be a proliferation of that bacteria within that lesion. And this will ultimately result in vegetation. So this is the examples of vegetations of IE in mitral valve. Vegetation is a typical pathologic lesion of IE. So the clinical manifestation, as for the symptoms, patient can present with fever, acute endocarditis. Usually patient has high-grade fever. Subacute endocarditis, patient has low-grade fever, and malaise, anorexia, weight loss, chest pain, arthralgia, and myalgia, which is joint pain and muscle pain. We need to remember when patient present with fever plus new murmur is endocarditis until proven otherwise, because heart murmurs was found in up to 85% of patients with IE. As for the signs of IE, patient can have pallor. This is due to anemia, finger clubbing, but usually finger clubbing is a late sign of IE. Then tachycardia as well as cardiac murmur. The stigmata of IE, such as splinter hemorrhage, osseous nodes, genuine lesion, as well as rough spot. Splinter hemorrhage, it is normally seen under the fingernails or toenails, and usually is red-brown in color. And then the osseous node is a painful subcutaneous nodules in fingers or toes. We need to remember 4P to identify IE. To identify osseous node, first is painful, and then is pink purplish in color, and then it is pea size, and also the site is on the palm of fingers or toes. Genuine lesion is a non-tender lesion that is usually hemorrhagic, and then the rose spot is a retinal hemorrhage and usually has pale or white center. The investigations and diagnosis of IE I've divided into 4, which is the lab investigation, the blood culture, which is a key diagnostic of IE, and then echocardiography as well as other investigations. Okay, so these are the lab investigation finding for IE. As for the blood culture, patient can have a positive blood culture, and then the full blood count will show a normal chromic normocytic anemia that indicate anemia of chronic disorders. And then ESR or CRP is elevated in patient with IE. And the renal profile shows exothermia, ANA and rheumatoid factor is usually positive. And then liver function test shows increased ALP. And then urine full examination and microscopic examination shows a microscopic hematuria as well as proteinuria. But all of these investigations except blood culture is a non-specific investigation because the blood culture remains the cornerstone of diagnosis of IE. So 3 to 5 separate blood collection is usually obtained to diagnose IE, but 85 to 90% are diagnosed from the first 2 sets of blood cultures obtained. And then imaging such as echocardiogram, a combination of TTE and TEE will enhance the ability to diagnose IE. So the usual findings we can find vegetation, abscess, pseudoaneurysm, fistula, and valve leaflet perforation. TTE should be performed as soon as possible when IE is suspected. But if the initial TTE is negative, we need to do a repeat TTE, or we need to consider to do a TEE within a week. But we need to carefully consider TEE in children because TEE requires general anesthesia. So these are the echocardiography showing vegetation in the native posterior mitral valve leaflet. And then other imaging modalities to diagnose IE such as cardiac CT, brain MRI, nuclear imaging, and regular ECG. So modified Duke criteria is used as a guide to diagnose IE, and then it has major and minor criteria. Major modified Duke criteria is when patient have blood culture positive for IE, and blood culture is showing a typical microorganism consistent with IE from the 2 separate blood cultures obtained, such as Viridian streptococci and Streptococcus galolyticus. Microorganism consistent with IE from persistent positive blood cultures, as well as patients who have a single positive blood culture for Coxiella burnetii or phase 1 IgG antibody titer of more than 1 to 2,800. And then when patient have echocardiogram positive for IE showing vegetation, abscess, pseudoaneurysm, intracardiac fistula, valvular perforation, or aneurysm. So the minor modified Duke criteria is when patient have any predisposed heart condition or patient is IV drug user, and patient who have fever of more than 38 degrees Celsius, and patient who have vascular phenomena such as Janeway's lesion, immunological phenomena such as osseous nodes and rose spot, and patient who have a positive blood culture but does not meet the major criterion as noted in the major modified Duke criteria. So this modified Duke criteria is used because it has a clinical sensitivity of 80%. So it can be divided into 3, definite, impossible, as well as rejected. A definite IE is when patient has a pathological criteria, when patient has a when patient demonstrate with a histology of a vegetation, a a vegetation that has embolized or intracardiac abscess specimen, or pathological lesion such as vegetation or intracardiac abscess confirmed by histological examination showing there is presence of active endocarditis. And then clinical criteria, patient who have 2 major criteria or 1 major and 3 minor or 5 minor criteria. Possible IE is when patient have 1 major and 1 minor or 3 minor. Rejected IE is when patient have firm alternate diagnosis or resolution of symptoms suggest IE with antibiotic therapy. Antibiotic therapy is one of the treatment for IE. And then no pathological evidence of IE as surgery or autopsy. And patient who do not meet criteria for possible IE as what I've mentioned earlier. So why we need this modified Duke criteria? Because modified Duke criteria help us to further assess this patient, because patient who have definite IE, we treat that patient as IE, but patient who have a possible IE, but the clinical suspicion is still high, we need to do a repeat TTE or TEE, and then we need to revise the diagnosis again. And then patient who have a rejected IE, but clinical suspicion is low, then only we look for other causes instead of IE and treat patient as bacteremia. So as for management of IE, so the major goals of management is to eradicate the infectious agent from the endocardium as well as to address the complications of the infection, both intracardiac and extracardiac complication. So the antimicrobial therapy, the general principle is to use a bactericidal instead of bacteriostatic agents to achieve effective treatment for IE. And then the initial high dose parenteral route to achieve high bactericidal effect, as well as to have adequate duration to ensure complete eradication. Usually the duration to give antimicrobial therapy is 4 to 6 weeks. And we need to use empirical antibiotics until culture results are available. So these are the antibiotic regimens for initial empirical treatment. So different types of endocarditis have different antibiotic regimens. So we need to memorize all of these. And then once the causative microorganism is identified and sensitivity pattern is obtained, the empirical regimen should then be switched to a definitive one. So these are the antibiotic regimens for a definitive treatment of IE. So different organisms involved have different antibiotic regimens and different duration to give that antibiotics. So again, we need to memorize all of these antibiotic regimen. Okay, surgical intervention. When surgical intervention is indicated, it is when patient have following cases such as heart failure, uncontrolled infection, as well as prevention of embolism. When patient have left-sided vegetation of more than 10 mm after one or more embolic episode, as well as patient who have very large vegetation of more than 30 millimeter. So this is the summary of clinical management of IE taken from CPG of IE. And then the prevention of IE, in high-risk patient, prophylactic antibiotics are required before and during all dental procedures, as well as invasive procedures of the respiratory tract, infected skin or muscle. So oral amoxicillin is taken 30 to 60 minutes before the procedure. This is the recommended regimen for high-risk patient. Clindamycin or azithromycin are the alternative regimen if patient is allergic to oral amoxicillin. But the prolonged or continuous antibiotic prophylaxis is still not recommended even in high-risk patient. So the complication of IE. So a patient who have IE can present with complications such as cardiac complication, renal complication, pulmonary complication, neurological complication, musculoskeletal complication, as well as complication related to systemic infection. So the cardiac complication is the most common complication in IE. So the heart failure is the most common cause of death in IE, and also the most common cause for surgical intervention in patient suffering with IE. And then patient can have renal complications such as glomerulonephritis when patient due to immunoglobulin deposition. And then patient have pulmonary complication that can present with pneumonia, lung abscess, pleural effusion, as well as pneumothorax. As for neurological complication, patient with IE can present neurological complication is one of the presenting symptoms for IE. So we need to suspect IE when patient present with any neurological complications such as abscess, stroke, as well as meningitis. And musculoskeletal complication such as septic arthritis, vertebral osteomyelitis, and also metastatic abscess, septic embolization. So the prognosis of IE. So the prognosis of IE caused by the most common organism, which is I've mentioned earlier, Streptococcus viridum, is often good, where the cure rate is more than 90% in uncomplicated endocarditis caused by viridum streptococci on a natural valve. 75 to 90% for Enterococcus endocarditis, and 60 to 75% for Staphylococcus aureus endocarditis. But when patients have gram-negative bacilli and rarer organism endocarditis, patient can have poor prognosis, and poorest prognosis if patient have fungal endocarditis. I've mentioned earlier, fungal endocarditis is rare, but when patient have fungal endocarditis, patient can have more serious complication compared to bacterial endocarditis, even with a cure rate of about 50% with valve replacement. So these are my references, and thank you. Any question?
Okay, thank you Nabila ya. Right. So basically IE itu the infection that happen on the endocard with to the some high risk individu ya. So tadi kalau ada the risk factor tu ada yang high risk, moderate risk dengan yang low risk ya. Usually patient to simplify patient with heart disease, especially yang valvular and yang multiple multiple or complex cyanotic congenital heart disease usually will have high risk to develop IE. So patient like this too, we need to prevent IE and try to make the patient to bukan clear has no risk of infection ya, has less risk of infection by doing the tonsillectomy, dental extraction, and so on and so forth. If develop IE, so these are the criteria tadi of the diagnosis. You need to read in details ya, what are the pathological criteria and clinical criteria. Pathological ada dua ya, the microbiology, the blood CNS, and the echo findings ya. So ada kriteria gitu. Kalau blood CNS kena, kalau from blood CNS kena at least 2 positive samples in take 12 hours apart, atau kalau from different site kena at least 1 hour apart ya. So ada few yang di slide nya. So ada kriteria itu is very details, and then you learn how to diagnose ya. So clinically can be definite IE, can be possible or unlikely IE. Okay, so any questions? No interested nggak? Dah penat semua ke? Putri Azlan. Putri Azlan.
Doktor.
Okay, so what are the stigmata of IE?
Generation, oscillator node.
Dua je ingat, ada 4.
A splinter hemorrhage.
Okay, lagi satu. Kat mata apa?
Rough spot.
Spot, okay. Okay, nak tanya, tak. You dah tahu semua ke? Nak tak tanya ni, saya tanya siapa? Nabila. Why yang oscillator tu painful and then while the generation dia painless? Kenapa?
Sebab pula. Because in oscillus node, there is inflammation, presence of bradykinin. This is what I read lah. And generation is painless because that is just immunological response towards our body.
Okay. Alright,
Sure.
yeah. So semua, hope you understand, yeah. It is 2 different mechanism, yeah. The one is inflammatory, should be painful due to bradykinin, and then another one will be immunologic phenomenon only, yeah. Should be painless.
My slide. Sorry.
Okay, I have concurrent meeting, so double meeting, ada meeting for research grant. Okay lah, so any more questions? Tak ada, alright. So proceed with the third presentation. Siapa tadi lupa? Husna ya? Rukniatul Husna.
Tak boleh nak share my slide.
Ya, Doktor. Can you see the slide?
Can? Yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I, Untitled Chapter, will present the topic heart failure in childhood. Another name for it is pediatric heart failure, PHF. This presentation we go through definition and physiology, and then we go to etiology, pathophysiology, clinical manifestation, investigation, management, complication, and lastly prognosis. For the definition, heart failure is defined as when the heart is unable to deliver adequate cardiac output to meet the metabolic need of the body. And there are several factors can affect the cardiac performance or cardiac output. On the table itself is preload, afterload, contractility, and heart rate. For the better understanding of this factor, we can use the formula cardiac output is equal to heart rate times stroke volume. Heart rate is mostly influenced by the atrial reflex, autonomic innervation, and hormones. While for the stroke volume is defined as the volume of the blood injected in one cardiac cycle, which we can see through this formula, N diastolic volume minus N systolic volume, EDV minus ESV, and there's several mechanisms how this can regulate EDV and ESV, which is the preload, contractility, and the afterload. And so, if in cardiac failure, if the cardiac output is decreased, so it's maybe due to the heart rate is decreased or the stroke volume decreased. So that's the general idea I want you all to grasp for this presentation. Next, we go to the etiology. In children, cardiac failure is most often due to congenital heart disease and cardiomyopathies. For specific age, congenital structural heart lesion is most common during infancy. Meanwhile, but for example, like congenital structural heart lesion is like VSD, ventricular septal defect, ASD, and so on. Meanwhile, for primary myocardial like example like cardiomyopathy And acquired valvular disease, like this presentation before, is infective endocarditis is more likely to present in older children. And I also include the table for a specific age with specific diagnosis from fetus until child or adolescent. Okay, then we go to pathophysiology. As we remember before, the point of inadequate cardiac output, right? So it may be influence of heart rate and the stroke volume. Under these two factors, there's also mechanism that eventually lead to either the ventricular dysfunction or abnormal loading condition. First, ventricular dysfunction. Ventricular dysfunctions can either be systolic or diastolic dysfunction. For in systolic dysfunction is because the reduce of the ventricular contractility, while for diastolic is for the decreased ventricular compliance to take up the blood in the heart, maybe due to the due to decreased ventricular relaxation or an increase of ventricular stiffness itself. And the diseases that may due to ventricular dysfunction include cardiomyopathy, myocarditis, MI, ischemia, and arrhythmia. Next pathophysiology is the abnormal loading. For abnormal loading, is made due to preload or afterload problem. And for preload, volume overload, or another, we can also occur due to the moderate or large left to right shunt due to causes like ventricular septal defect, patent ductus arteriosus (PDA), and arterial septal defect (ASD. While also take note that volume overload can also occur due to valvular insufficiency from regurgitation like aortic regurgitation, mitral regurgitation, and pulmonary regurgitation like Iqbal explained before. And okay, we go to next is pressure overload or afterload problem. It may be caused by the cardiac disorder with ventricular outflow obstruction. I repeat, ventricular outflow obstruction, and it's because it prevents the ejection of blood from the heart and it's resulting the decreased cardiac output. And the obstructive lesion may include aortic stenosis, coarctation of aorta, COA, and pulmonary stenosis. For stenosis is the explanation as like Iqbal just said just now. And for coarctation of aorta is for the next seminar. I also explain about it next. Okay, next we go to the clinical manifestation of PHF that divided into infant and older children. And infant may present with this listed which is pro-feeding, failure to thrive, tachypnea, and diaphoresis with feeding. What is diaphoresis? Diaphoresis is excessive sweating, berpeluh, due to the consequence of increased sympathetic tone due to compensation of the low cardiac output as the infant may have. And meanwhile, for older children, may present similar to the adult symptom that includes dyspnea, easily to be fatigued, and edema. For physical findings, it very depend on the cardiac output, degree of the volume overload, and whether it's pulmonary venous congestion or systemic venous congestion or both at present. One of the finding may be tachycardia. Tachycardia is present as due to the response of the body when the heart has reduced cardiac output. while for Gallup rhythm is with low cardiac output or when the patient have volume overload. Okay, for poor perfusion signs like cold and motor extremity, decreased capillary fill, decreased peripheral pulses, and low systemic BP can also be seen at PHF patient. Next, we go to and search for the pulmonary finding. For the pulmonary finding, we must take note because it may indicate the chance of the left-sided heart failure. And as listed here is tachycardia, one of the signs is tachycardia, autopnea, wheezing, and pulmonary edema. Tachycardia is the most common finding we seen in pulmonary finding. And while I also want to add that auscultatory finding like wheezing is more common seen in older patient, older children. Then we go to the systemic congestion signs, which may indicate there's involvement of the right-sided heart, which is the finding may be hepatomegaly, edema, and distended neck vein. The most common finding is hepatomegaly, and for the edema is most likely is also related with ascites and due to the hepatomegaly, and distended neck vein, as previously doctor say before, is not usually found in our pediatric patient because their neck is too short. Okay. Next, we go to the classification. From the history taking and the physical examination, we can classify PHF based on the severity. And we use two classification, which is the modified Ross classification and NYHA classification. For the modified Ross, we use in PHF in children aged less than 6 years, while NYHA classification for PHF patient with that is aged more than 6 years. Okay, the NYHA classification is followed as in adult heart failure. For the modified Ross classification, the class 1 we may classify it as class 1 if the patient is asymptomatic, and for class 2, if the infant is mild tachypnea or diaphoresis with feeding, or if the patient is older children, the dyspnea is maybe on exertion. For infant, in class 3, for infant, marked tachypnea or diaphoresis with feeding and prolonged feeding time with growth. For older children, mild dyspnea on exertion. While for class 4, in modified Ross classification, the symptom like tachypnea, retraction, grunting, and diaphoresis it can be seen at rest. Grunting is the respiratory distress occur when the patient is having low CO and it cannot meet up with the metabolic demand of the body, and we cause the baby to grunt. Dia macam mana bunyi ni? Okay, nantilah. And next I will share on the WhatsApp group. Okay, next we go to investigation. For investigation, we must do chest X-ray to assess the cardiomegaly or any pulmonary involvement occur due to the congestion of the left-sided heart failure. And also we may do chest X-ray to monitor the effectiveness of the heart failure treatment. And for ECG, like in previous topic, is also to assess the cause of the heart failure. However, it's not to establish the diagnosis. In ECG, the common finding is sinus tachycardia due to the compensation of the reduced stroke volume. For echocardiogram, the ultrasound of the heart is to assess the the size of the heart chamber to measure the myocardial function and to diagnose the congenital defect if there's when it's present on the patient. And for the lab test, we do BNP to assess the severity of the heart failure and to monitor response of the therapy, and also cardiac troponin markers 1 and T as to definite is there any how early is this myocyte injury. And for the CBC, we must look for the patient if there's any signs of anemia. And then we go to the serum chemistries. Serum chemistries includes all the electrolytes, BUN, creatinine, and LFT. And why we must do the serum chemistries? Because I listed there, hyponatremia may be seen in patients with severe heart failure, and renal impairment may contribute to heart failure, or if the patient already have the heart failure, it will worsen the heart failure due to the renal impairment. And also we do baseline electrolyte is needed before we want to initiate the patient therapy, and because we want to avoid any potential side effect of the diuretic and ACE inhibitor. And liver function study also may elevated in this test because if the patient have hepatic congestion with right-sided heart failure. Okay, the management approach should be tailored, should be focused according to the patient clinical status at presentation, and the underlying causes of the PHF. And the general goal of managing PHF is to relieve the symptom, to decrease the morbidity, to slow the progression of the heart failure, to improve survivability and quality of life of the patient, and also to remove or alleviate the underlying causes if possible. There are also specific goals for the specific etiology. As for congenital cardiac anomaly, we make sure the patient that is able to surgeon, we must prepare the patient for surgery, because before we want to do a surgery, we must make sure the baby, the patient have appropriate weight for the surgery. And cardiomyopathy, we provide temporary relief from the symptom and also may allow the patient to recover if the insult is reversible, and if the lesion is not reversible, we only manage the patient until the patient have ability to return to the normal life for some period or delay some need for heart transplant. For the general measure, we need to correct the reversible condition that may cause or contribute the symptom of heart failure, such as anemia, hypertension, and respiratory disorders, and many more. And also do strict bed rest and make sure the patient in prop up position. Then ensure the patient have adequate nutritional support. Why? Because when the patient have increased metabolic demand, they have increase of caloric need. And for salt and fluid restriction for children with severe HF to reduce volume overload. And also recommend to promote healthy and safe lifestyle with rational restriction for our PHF patient. For the pharmacological intervention, like Ikwan said before, is diuretic, vasodilators, and digoxin, which is like here is furosemide, spironolactone, nitroprusside, captopril, and digoxin. And for the non-pharmacological intervention, we have surgical and transcatheter treatment, pacemaker implantation, and heart transplantation. And for the specific therapy, I also shown this slide for our colleagues to read after this seminar. Is with from each therapy with each mechanism. Next, PHF is, as we all know, is the outcome of for cardiac disorders such as congenital heart disorders and many more. PHF can also progress to several complications. One of them can be thromboembolism. Thromboembolism can occur at children with heart failure due to systemic ventricular dysfunction, and because of that, they are at risk for thrombi formation that which eventually result to pulmonary embolus and cerebral embolic stroke. And progression of heart failure can lead to arrhythmia and sudden cardiac arrest. Finally, prognosis. The outcome of pediatric heart failure is largely depend on the etiology, and when the heart failure is due to the structural congenital defect, the surgery and or the interventional treatment may become curative, and this shows better prognosis. In some patients, however, it may become several etiology is only become palliative with some improvement in the clinical symptom. Right. I think that's all for me, and this is my references.
All right, yeah. Let me see. All right. Okay. Any questions, comments? Nurain, Anis, Najiha.
Yes, doctor. Yes, doctor.
Okay. So, what are the features of right heart congestion? Patient with right heart failure. Apa je feature yang you kena cari?
Shortness of breath, edema.
Right. Edema kat mana?
Edema might be because edema extremities.
Kat mana? Location.
I'm not sure.
Which
maybe,
extremities?
Legs, ankles, feet.
Okay, leg edema betul. SOB betul tak? Siapa? Husna, presenter. Right heart congestion dia shortness of breath tak?
Right sided tak rasanya. Tak. For my
Okay. SOB is left sided, ya. Okay, baru satu je yang betul. Leg edema. Siapa tadi saya nampak? Nur Hidayah.
Yes.
Next, siapa lagi?
Sorry, tak dengar sebab internet.
Right-sided heart failure, apa the features? What are the features of right-sided heart failure? So, dari tadi awal pukul 2 pun tak dengar apa-apa ke?
Sekejap. Edema.
Dia tadi lagi edema tadi dah lain.
Hepatomegali.
Okay, hepatomegali. Susahnya nak keluar. Izzah Zahira.
Ya, Doktor. Lagi satu distended jugular vein.
Sorry?
Distended jugular vein.
Okay, increase FVP pressure. Hanis Hamdan.
Ya, Doktor.
What about left-sided heart failure? What can you get? What other features? Tadi yang short compress dah, tadi yang lain apa?
Can be irregular heartbeat.
Irregular, okay lah. Tapi usually will be tachycardy. Tachycardy. Fawas Naim. Fawas Naim.
Yes. Hello.
Apa, what else? Left-sided heart failure. The features.
Pulmonary edema.
Okay. Shafika. Apa lagi? Left-sided heart failure. Kak Lang apa lagi? Despite pulmonary edema, you boleh jumpa apa?
Kak Lang. Wheezing.
Boleh tapi jarang lah. More common apa? Basal apa?
Capitation.
Wheezing, capitation. Right. Anis Najiha. Anis Najiha?
Ya, saya Doktor.
Alright, so when you palpate the apex beat, apa you expect patient with heart failure? What do you expect on palpation? Boleh jawab Anis Shafika saya dah belum? Ya. Apa? Anis Najiha?
Parasternal fifth.
Okay, for ventricular hypertrophy. Anis Shafika apa? Anis Shafika? Dah boleh Anis Shafika tadi? Saya pun lupa dah.
Dah, but it's okay, Doktor.
Apa?
What can we palpate?
Yes.
Displacement of apex beat
So due to? Sebab apa?
due to enlargement heart and cardiomegaly.
Cardiomegaly. Okay. So that's the features that you should get. Kalau dia tachycardia, usually sometimes kita sebut valve rhythm. Okay. So the features you kena faham, because it is important when you examine the patient CVS. First thing kan you need to evaluate, you need to assess whether the patient in distress or not. Respiratory distress is one of the symptom of left-sided heart failure. Kalau udah nampak dia ada in respiratory distress, ada in heart failure, you need to get those features. Ya. Cardiomegaly, maybe basal crabs. Kalau severe ya pulmonary edema, tapi itu for severe lah. Yang right-sided, jadi ini hepatomegaly as well as any like edema. Itu yang penting ya. Okay, maybe the last few lah. Aminah, treatment patient with heart failure, you kena bagi apa treatment? Medical treatment.
ACE inhibitor.
Okay, but it's not the first one. Yang first medication apa? Afika Atira.
Medication.
Yes.
For pharmacological intervention, Doctor.
Iya. Okay, ya. So yang reflex medication ya, it is apa namanya spinal reflex ya. So kalau you ada patient with heart failure tak payah fikir ya, reflex cepat je bagi furosemide ya. No need to discuss. Kalau macam ACE inhibitor bagi captopril or bagi what more bagi digoxin, you need to think carefully whether you want to give or not, whether you need to give or not. Usually we discuss lah with specialist or maybe consultant cardiology. But for diuretics, it is no harm ya. Any case of heart failure, regardless the causes, regardless the condition, kalau patient nampak shortness of breath, just directly give furosemide. Diuretics. Okay ya. So any more question? Anything else? Nak tanya apa-apa lagi? Okay, if no more question, we close today's seminar. Let us give a round of applause. Okay ya, so presenter semua dah clear ya. Okay, thank you all. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.